Good evening, everyone. Thank you for being here. On behalf of the NYU Meyers Alumni Association, I would like to welcome you to another Meyers Marbles event. My name is Jin Jun. I am a member of the NYU Meyers Alumni Association. NYU Rory Meyers College of Nursing is committed to producing lifelong learners who will excel in their nursing careers and be recognized as leaders who keep patient-centered care and the health of society at the forefront of their values. Meyers graduates hold positions of leadership in the profession, practicing in diverse clinical, academic, and administrative settings. The Meyers Marvel series shines a light on our most prominent alumni that have influenced the nursing profession. Tonight, we are very thrilled to speak with Dr. Diana Mason. Dr. Mason is she's a senior policy service professor at the George Washington University School of Nursing's Center for Health Policy and Media Engagement, and Professor Emeritus at Hunter College, where she founded the Center for Health, Media, and Policy. She's the Program Director for International Council of Nurses Global Nursing Leadership Institute and a past president of the American Academy of Nursing. A former editor-in-chief of the American Journal of Nursing, Dr. Mason has hosted health policy radio programs since 1985. She currently hosts Health Centera in the Catskills on WIOX radio. She has served on multiple national advisory committees, including Kaiser Health News and the National Academy of Sciences Committee on Integrating Social Care into Healthcare. She'll be the new secretary of the board of directors for the Primary Care Development Corporation starting in July, after serving as a director for 8 years. Dr. Mason is the lead editor of Policy and Politics in Nursing and Healthcare and was a regular contributor to JAMA Health Forum for over a decade. She has received numerous awards for her contributions to health policy, leadership, and advocacy. And this event tonight will be moderated by our own by Dr. Sharon Wexler. Dr. Wexler is the president of the Meyers Alumni Association. She serves as a professor, department chairperson at Pace University College of Health Professions. So back to you, Dr. Wexler.
Thank you. I'm really honored to be here and have the opportunity to talk with Dr. Diana Mason. So, Diana, can you start out by sharing a brief overview of your nursing career? And as you do, tell us what inspired you to become a nurse leader and how your journey has evolved.
Well, first, let me thank you for inviting me to do this. This is really wonderful to see so many friends and colleagues who I've worked with over the years. I see Jane Seeley, my good friend and colleague, Barbara Glickstein, Christy Westfan, Sean Kennedy, I mentioned, Richard, so many people. And it's really great to see you all. It's a reminder of that it takes a village to really do good work. And I appreciate all of the opportunities I've had to work with those of you who are here. I want to start with talking about the importance of a good undergraduate nursing education in formulating how people see the world. I did my undergraduate work at West Virginia University in the late 60s. And in the early 60s, it had just opened. And with the most innovative curriculum that I have ever seen a nursing school have, including today. We focused on public health and on transitions of care, as well as the usual med-surg, maternity, peds. But we would do things like see a woman prenatally, be on call for when she went into labor and delivery, and actually go into the delivery room with her, if at all possible, and then take care of her postnatally and make a home visit. We followed a developing family the whole time we were in school. Now, my family got divorced, so I'm not sure what it says about me as a public health nurse, but it was a very important experience and really shaped how I thought about the impact of poverty on health, because the family was in a very poor part of West Virginia. And so it was just this transformative nursing education that helped me to think about not just the health of an individual when they're sick, but the health of families and communities. Now, I did work in acute care, in critical care when I graduated because I didn't have enough money to get through school. My father had 5 kids, and he said, you know, on an engineer salary, you're going to have to figure this out. But he said, I'm going to help you. And at the age of 18, he said, come with me down to Pittsburgh. I'm going to get your school paid for. And he took me to the Army recruiting station and he said, sign here. And so I signed on the dotted line thinking, well, I'll have a job when I'm done. And for the last 2 years of my school, the Army Nurse Corps paid for my tuition, fees, books, and a stipend. In August of 1970, I had to go to basic training after being tear gassed in May for protesting the Vietnam War. So there was a lot of cognitive dissonance. And in fact, the military was probably not the best fit for me. I did not stay beyond my 3 years. And I don't think the Army really wanted me to stay beyond my 3 years. But I worked for all those 3 years at Walson Army Hospital at Fort Dix, New Jersey, in critical care. And like most, it was a medical and coronary critical care unit. And like most critical care nurses, I thought I was super nurse. I could start an IV on anybody. I was teaching arrhythmia classes to nurses. I was resuscitating people. I was a hotshot nurse. And then my father became seriously ill. He had multiple health problems. He died at the age of 58 of cancer, and I took care of him the last month that he was alive. And when I was taking care of him, I realized it wasn't that super nurse in a critical care unit that made the difference. I made a difference in people's lives, but it really was about the basics. It was about knowing how to turn, how to bathe, how to feed small, frequent feedings and make nutrition something that the patient would want to do, not feel they had to do, or not eat, and how to be with somebody at the end of their life. And so it really was transformative to me to rethink, what did I want out of nursing in my career? So I went to a master's program at St. Louis University, where I focused essentially on community health nursing and had 2 wonderful mentors in public health and in health policy, and came to New York and was at Hunter College to start, and believed that faculty or teaching clinical should walk the talk. So I started with 2 other faculty members of private practice, only to find out we couldn't get third-party reimbursement and we couldn't get corporate insurance coverage. And so I became very engaged. The personal is political. I became very engaged in trying to change third-party reimbursement laws in New York, and involved in the local nurses association's legislative committee, then on the board, and then as president of that association, getting involved with the New York State Nurses Association and ANA. So that was really when I really became more politically engaged, and seeing the connection and the context of policymaking in terms of the political. And it was when we started the book, Policy and Politics in Nursing and Healthcare. And Monica McLemore is here. She's now one of the co-editors, and we're working on the 9th edition of that book. Yeah, and it's been great fun to work with her. So the policy piece has been a major focus for me, and one that I have combined with my writing, which brings me to my AJN experience. And I want, for those of you who feel like you have to plan out your career, yeah, maybe, but sometimes it's the serendipitous things that show up. And if you seize the moment, it can take you down a path that is wonderful. And so I was on the editorial board of the American Journal of Nursing, and I really felt the journal had gone down the tubes. And so I went to an editorial board meeting and said, I think the journal needs to stop dumbing down to nurses, and it needs a major graphic overhaul. And I figured they would kick me off the board, and they didn't. And 3 months later, they asked me to apply for the position of editor-in-chief of the journal. Well, I was tenure professor at Pace University then. And I decided that I should think about it. And what vision did I have for the journal? And this has been another major focus of my work. What is my vision for it? If I don't have a vision for it, where's the passion? So what's the vision? And so I interviewed with Jay Lippincott, the great grandson of the Lippincott, John Lippincott, who started the Lippincott Publishing Company. And he said to me, Diana, why do you want to be editor of the American Journal of Nursing? And I said, I don't want to be editor of the American Journal of Nursing as it is now. I only want to be editor of a transformed journal. I want to transform it within the nursing community. It needs a major overhaul graphically as well as in terms of journalistic standards. We have to quit dumbing down to nurses, but we also need to make it highly readable. Second, I'm reading the New England Journal of Medicine and JAMA. Why aren't they reading us? Why isn't the physical therapist, the social worker reading the American Journal of Nursing? We publish articles that they should want to know about. And third, the public should be reading the journal. The public is reading things out of JAMA and the New England Journal, but what we're writing and publishing is even more relevant. And I want to turn on the nightly news and hear, instead of this week in the New England Journal of Medicine, I want to turn it on and hear this month in the American Journal of Nursing. And I said, so that's what I want to do. And if that's not where you want to go with the journal, then don't pick me. Don't put me in the running. We chatted some more. He said, well, you'll be in touch in a few days. And they called me the next day and offered me the position. And so I said to him, and this is where you have a vision, but as I think it was Albert Einstein said, a vision without action is a hallucination. And so you have to be strategic about the actions that you're taking to achieve that vision. And so I knew that change is hard. And while I got everybody on board, supposedly director of marketing and advertising, the publisher, continuing ed, et cetera, with what the vision was for the journal and a strategic plan, that carrying it out was going to be another matter. And indeed, when the first budget came up, there was no money in a budget for media outreach. And I had taken a leave of absence from Pace. This was another part of my strategy. I was tenured professor at Pace. I took a leave of absence and said to Jay Lippincott, for a year, we can see if this is the right fit. And if it isn't, we can both walk away, or one of us can walk away with no harm done. And that was really important because it gave me leverage. So when the budget had no money in it, I said, without some money for a media strategy, there's no way that we can achieve that third aim of the strategic plan. And if we're not including that third aim, then I don't know that I'm the right person for this job. And I got the media budget, and we were on the nightly news. We were publishing a series of articles in particular on taking family members into codes and invasive procedures. We were on the front page of the New York Times, the Wall Street Journal. We were on CNN, ABC World, and I don't mean I don't mean me. It was the journal and the authors. And so we got huge media coverage and continued to get huge media coverage for the journal. So that by the time I left, and we raised the standards for the journal journalistically. We adopted the standards of the International Committee of Biomedical Journal Editors. By the end of my tenure there, I felt totally gratified that because of this team of people that have worked so hard on this journal, we were selected by the Specialized Libraries Association as one of 100 journals of the century, influential journals of the century in biology and medicine. And we were the only nursing journal on the list. Now, it wasn't just because of the tenure when I was there. It really was the history of the journal. But had we not restored the journal and elevated it to a place of integrity and excellence, I don't think that would have happened. And Sean Kennedy is here, and she worked very hard to continue that tradition of excellence for the journal. So I think, AJN I developed my writing chops really at HAN. And so JAMA News Forum came knocking and said, we'd like you to be part of a team of contributing columnists to write about policy now that Obama and the Affordable Care Act is moving forward. I was the only nurse, and I will tell you, I felt totally intimidated. The other people who had been invited were people like Gail Walensky, who headed up what is now CMS. It was HCFA then, the Healthcare Financing Administration. And David Cutler, who's a major health economist. Larry Levitt, who drowns in data at the Kaiser Family Foundation. And I was really feeling like, should I be here? And I thought, wait a minute. I have perspectives that these others do not have. I understand the impact of policy on human lives, on individuals, families, and communities, and that's what I'm going to write about. And I am proud to say that when I left, I was the last to be asked to leave. They were rotating people off and new people on. And the woman that I was working with as an editor said to me, you know, we've really put off asking you because you write about things nobody else writes about. I was writing about social determinants of health, period poverty, maternity care deserts, often with other people though. I would bring on others who had deep expertise in an area many times. And she said, and you approached it in a way that with a voice that none of the others had. So one of the lessons there is to trust what we bring to these tables, and that it's important that we use our voice and use them to do that health promotion. So my career's been very diverse and it's been very rich. I'm now continuing in my preferment, Sharon. I'm retired, but in preferment, doing what I prefer to do. And what I'm preferring to do is try to get nurses and health professionals and the public to understand that we don't need to pour more money into acute care. We need to right-size acute care and pour money into primary care and building healthy communities. And I'm trying to do that. I'm now living in the Catskill Mountains, where I'm trying to bring an FQHC to our primary care desert. That's all on hold right now for federal obvious reasons, but we're not giving it up. So yeah, I'm continuing to bring my expertise to my community, and I can tell you it's very much valued by the community. So I want to encourage everybody here, if you're not already involved in leading some way in your community, to do so.
Thank you, Diana. Wow, is all I have to say. Very, very inspiring. So moving along, can you share your experience working with the Global Nursing Leadership Institute? What are some key insights that you've gained from doing this?
Yeah, this is sort of a passion of mine now. GNLI, as it's called, is an ICN, International Council of Nurses signature initiative. It started in 2009, and I was brought in as faculty mostly by Stephanie Ferguson, who was directing the program in those early years. And then I became facilitating and co-directing, and now I'm program director. In 2020, so this program was, people would come do a little bit of prep work and then spend a week in Geneva, including a half day at the World Health Organization. And during COVID, it was like, well, I guess we have to stop it. And I'm like, no, COVID doesn't mean we need fewer leaders. We need more leaders. Let's move it online. And I got some pushback on that by the person who was then directing the program. And I said, look, I'll do it. I can see how to do it. We can do this. So I became program director and we moved it online. Well, when you move an international program online, you can't have everybody on at the same time. You can every once in a while. Somebody has to get up in the middle of the night, but you don't do that often. So we organized the scholars in their WHO regions. So the Pan American Health region, the Euro region, the Western Pacific region, et cetera. And we had faculty who would facilitate in those regions. And we developed partnerships with the regional WHO offices, which has been very rich. And now so we did that. And then 2023, we went back to the Geneva experience. But the silver lining of COVID was that we were able to build a stronger program. We have kept that regional focus for the module 1, we call it, before they come to Geneva. And they select a project that they're going to work on that matches the priorities of the WHO regional office. And in some cases, they work very closely with the lead for nursing and midwifery from that regional office. And then they keep working on their project while they're in Geneva. We go a full day in Geneva, and now WHO wants us to go a day and a half. And then they continue after that week to work on their projects. And now we have these WHO regional leads saying, I want to be a co-author on that paper. Or in one case, where the scholar's work has now been adopted by ICN and the WHO. It was a European project on nurse migration. They did excellent work, and it's now reflected in the work of ICN and WHO. So this idea that we can prepare nurse leaders to be actively engaged in developing policy regionally and globally has been really rich, and we've seen the program grow. The one point that has been distressing to me is I firmly believe, and Chris Kovner was on a paper with me. We worked with, Sally Cohn was the first author. Chris was on it, Julie Sahalski, Judy Levitt, and Joyce Pulcini and myself. We published a paper in Nursing Outlook called The Stages of Nurses' Political Development. And stage 1 was where, well, nursing's not at all involved in policy. Stage 2 is, oh, we're involved in policy, but it's all about us and nursing. The highest stage of political development is when nurses are leading on the broader health and social issues of our time. And so that's what I'm aspiring to. How do we lead on these be leaders in this space? And so, and the applications for GNLI, now some of these are chief nurse officers of countries, they're CEOs of healthcare organizations, they're deans of nursing. They are writing applications that talk about nursing. And when we ask them, what is one policy issue you'd like to address? It's nursing, a nursing issue. We've got to get out of our silo. And I will tell you that we were taking the most seasoned nurse leader applicants. And in 2023, a young nurse by the name of Casey Belgard applied to GNLI. She's an American nurse. She was younger, she was not in a senior position, but she wrote an application about climate change and the importance of climate change. And I said, we've got to take a risk on her. We've got to see what she can bring to this. And by God, when we went to WHO, she actually facilitated a session with some scholars and one of the leaders in WHO on climate change. And she brought it into all of our discussions. I mean, she was really amazing. So when we are ready to go into those spaces, we can and we do lead. So one of the lessons is, and I'm still trying to figure this out, in low resource countries, they have to develop the nursing workforce if they're going to do that kind of broader work. But in the United States, in Canada, in many European countries, we should be out there leading on the broader health issues of our day. So those are some of the lessons that I've learned, and it continues to be a really rich and inspiring experience for me.
Thank you. Very exciting. So let's move on a little bit. You've done a lot of work with nurses serving on boards. Can you talk a little bit why it's so important and how nurses can make an impact when they're serving on boards?
So the first Future of Nursing report called for, one of the recommendations was increasing the number of nurses serving on boards, commissions, task forces, et cetera. I'll just say boards, and getting 10,000 nurses on these boards. These are not nursing organizations. These are non-nursing organizations. And it could be of any nature. It could be a hospital board. It could be a task force on housing in your community, whatever. And I was involved in the formation of Nurses on Boards Coalition. It's been quite successful. And so I had already been trying to step up and was on the board of Public Health Solutions. I want to say Chris maybe was on that board. I'm not sure, Chris Kovner. But I was the only nurse at that time. And And it was a really valuable experience. And I felt like I was able to bring my voice to an important table. I was also, and still, I resigned from that position when I moved up here to the Catskills because Public Health Solutions is a nonprofit, large public health organization focused on New York City. And I felt like it needed somebody who was still living in New York City and understood the needs of New York City better than I was understanding them. And so I made 3 recommendations to them of nurses to consider, and they selected Dr. Kenya Beard, who's the dean at Mercy College. And so that succession planning is really important. It's not enough for you to just get at the table. When your time is up, you need to make sure that you're opening the door for another nurse to be at that table. So I want to just share with you about the Primary Care Development Corporation. I'm still on that board, and as was mentioned in the intro, I've served 2 terms as a director. And let me just say the Primary Care Development Corporation is a CDFI, a Community Development Financial Institution. CDFI, the only one in the country, it's nonprofit, devoted solely to building primary care capacity, first focused on New York City, then New York State, now nationally. So I was the first and only nurse on that board. I served 2 terms, and during that 2 terms, I've gotten 2 other nurses appointed to the board. And when I stepped down from this position, which I thought was going to be in July, I will recommend another nurse to take my place. And they came to me just a couple months ago and said, your term is up in July, but we would really like you to stay on, and wanted to know if you would take the position of secretary because our bylaws allows you then to stay another term. And I said, I would love to. I love this organization. I'd love to. So why did they ask me to do that? Why was I being valued? And I'm going to tell you why I think it is. One is that I'm always prepared. I'm probably overly prepared. I even read the 990s. The 990s are the nonprofit's statement to the IRS that are like 60 some pages long. And in the first one I read, I picked up a decimal point error, and they were blown away. Nobody ever reads the 990s, but I picked up the error. And the chief financial officer wanted me to go on the finance committee. I said, that's not, my strength isn't finance, it's editing. I could pick up that decimal point error, and I'm not ignorant about math. So I'm prepared. And when I'm prepared, I'm making notes of things I don't understand, and I'm not afraid to ask a question. Can you explain this to me? I don't always have to make a statement about something or offer my opinion. I do when I feel like I have something to offer, but I make sure I'm speaking at every meeting, even if it's only to say, I move the minutes be adopted. I'm using my voice. My voice has been heard. So I'm always prepared. I am engaged and pay attention. I also do the succession planning, as I mentioned, and the ethic of you give or get. On nonprofit boards, you're expected to give money or get money. And one of my most disappointing aspects of serving on a board has been the extent to which the nursing community is not supporting other nurses who are in these positions when they have to get. So the give can be 5,000 or 10,000. My money's coming out of my retirement fund, but it's worth it. And I send emails out about the gala to buy people to buy tickets. I will email chief nurse officers, deans. And by the way, Dean Amar has stepped up and is buying 2 tickets for, I think, nurse practitioner students to the gala that's coming up in June. But I can't begin to tell you the number of times when I get no reply, or I get a reply back, well, I can't come this year. Well, I'd like you to come, but that's not the point. Make a donation, $100, I don't care, $50, something. And for some people who I know are making millions of dollars a year, to have them say, well, I give my money to such and such. Well, excuse me. I'm out here trying to help primary care understand the role of nurses in primary care. And I don't have your support for that. So I think we're not used to playing at this level. And, I try to get organizations to even be sponsors, and I've had a couple successes, but by and large, it's really a hard row to hoe. So I want to encourage all of you to think about, if you know somebody who's on a board, what are you doing to support them and helping them to be a really credible leader on that board by buying a ticket to their event. Barbara Glickstein will buy a ticket to every gala the PCDC has while I'm there, I know. And I buy a ticket to her Project Kesher. She's chair of the board of Project Kesher, and I buy a ticket to her gala. Even if I can't go, I will buy a ticket and we'll find somebody who could use that ticket. So I think it really is about bringing our voice to other tables, but we have to understand what is expected if you want to play at that table.
Thank you. Those are very wise takeaways. So as we're running out of time, I wanted to ask you one last question. I'm fascinated by the fact that you have a radio show. So can you tell us very briefly what inspired you to start your radio show, how it's evolved, and tell us one memorable moment or impactful discussion that you've had on the show.
So I didn't start it. It was started by Diane Mancino and Paula Tedesco back in the 1980s. And they had a monthly program called Every Woman's Space. And they decided they had done it for a while and they were ready to do a handoff. And both Barbara Glickstein and I had been guests on their program, and they invited us to take it over, which we did. And then we gradually moved to being a weekly program. And we were the only nurse-produced radio program in the region, and in the early days, almost anywhere else in the country. Our focus is not nursing per se. It's on health policy, healthcare issues, but we probably have had more nurses on our program than any other radio program. It's been I have two experiences I want to share very quickly. One is, early on in my experience with this, the radio station was located on 8th Avenue in the 30s. I was walking from my apartment on 44th Street, and I was having a panic attack. I was like, oh my God, there are hundreds of thousands of people are listening, and I was worked myself up into a tizzy. I thought, Diana, what are you doing? I thought, you know what you're going to do. You have a script, essentially, that I follow, a run of show, as we call it. And, take a deep breath. You know how to do relaxation technique. Breathe, breathe. And it made a huge difference. And I got through the program. And I've made many faux pas, but you learn from those. So you can't expect to be perfect. But if you don't take a risk, if you don't step out there, you're not going to be stretching yourself. You're not going to be at the table. The other experience that I'd like to share really does speak to the power of our voice and how our voice is different. I was doing a program on urinary incontinence, and I had a hotshot urologist who was coming on, and Diane Newman, she's a superb, I don't think she's practicing anymore, clinical nurse specialist in urinary incontinence, fabulous. And the urologist was late to the studio, and Diane and I had already started the interview. He walks in and he sits down and he decides, because he's the physician, he's the one who he should answer everything. And I had to really wrest control of the interview from him. He was trying to be dominant. Well, we took a listener call, and the listener said, my wife's mother has this problem. She lives with us, and it's really a problem. The furniture, is starting to smell and blah, blah. And this physician jumps right in and says, well, she had this dynamic test and this test and this and that, all this jargon. And you can hear the caller's voice became very hesitant. And he went, well, I don't think so. I guess maybe we should have. I don't know. And Diane steps in and says, have you thought about having the conversation with your wife about her mother's problem and how to approach it? He said, well, I'm not really comfortable doing that because she has the same problem. And in that moment, Diane then talked to him about how to have the conversation about having urinary incontinence and how they might approach it both with his wife and with his mother. And it was a profound moment for me. It spoke volumes to the difference in what many physicians bring to the table versus what nurses can bring to the table. So do not devalue your voice and your perspective. It was a really important lesson.
That's a really powerful way and a good message to end the formal questioning. So if you have any questions, please type them into the chat and we'll get to as many as we can. So Diana, we do have one question. The question is as following. Let's see. I've worked with ICN, WHO, CGFNS, and HHS on addressing the nursing workforce shortage, which I know is near and dear to your heart. My question for you is this. Given the administration's goal to reduce foreign workers, how can we seize the opportunity to expand efforts to grow our own? Could this be a silver lining to the current crisis we're facing?
I don't even know what to tell you on that. I feel like we are in such a mess right now. It's going to take decades to rebuild what we had. And I don't think we can do it without the public support. The public support for nursing workforce has been really substantial. We were looking for more, but to have that be undermined, I mean, CMS has just rolled back its work on primary care in the AHEAD program. It's just cut that program. It stopped funding that program. I think it's gonna see some of the contracts through, but it's gonna end early. It's just stopped its guidance on integrating social care needs into Medicare and Medicaid and the Z codes that we're paying for that social care need interventions. We are Medicaid. There's no funding for new access points for FQHC. So my project up here is at a standpoint. Medicaid cuts are going to devastate FQHCs because a high percentage of their patient population are Medicaid, patients with Medicaid coverage. Immigrants are no longer going to the FQHCs because they're afraid of being picked up by ICE. We are in a terrible place. And my answer is not focusing on the nursing workforce right now. I'm sorry. It's getting out into the street and saying hands off our democracy, hands off taking NIH and funding for NIH and grants and now they're attacking journals and saying to the journal, how are you living up to the executive orders of the president to be able to comply with our orders around diversity, equity, and inclusion, and not using those words as well as, one of the words on the list that you cannot use is women. I hope you all know that. Women. So I'm totally not on that same level. And if you have ideas for that, please go ahead and share them because I'm right now feeling like I need to be out here saving this democracy and trying to figure out how do we stop this madness. It's true madness. I'm not even looking at my retirement fund. Can't do it. Can't go there. And I was just on a call today with somebody from Australia. They're all watching it, and she said to me, the global effect is just devastating, and I don't think Americans really appreciate that, and some Americans don't care. So I'm sorry, I'm a little bit too cynical about what's going on to think about how it's going to affect the nursing workforce.
There are quite a few other questions in the chat that directly relate to that. We are in challenging times. Can you give us advice on how to best fight? I think you answered a little bit of that. Anything else that you'd like to share?
Yeah, I think we have to, if you care about these issues, we have to start doing what people in South Korea did. And that is taking to the streets in peaceful ways and saying this is not okay. We also have to use our voices. And how do we use them? Get the stories. What is the impact of these changes on the people that you know, the people you take care of? They need the stories. When you tell the story of how a cut in Medicaid or a cut in social care needs affected somebody, an individual or a family or a whole community, people remember that. They understand it. But when you just talk about, well, we're going to cut Medicaid, people don't care. It's really what impact does it have on people. So get the stories, share those stories. I give money now to organizations that are filing lawsuits because that's a way to, one, slow the process and to stop some of this. Yeah, Monica McLemore knows all about this, and I took her advice supporting Democracy Forward. She told me that was the organization I ought to support. Between that and ACLU, I'm supporting legal action to try to stop and slow down things. You know, when we can deport people and deprive them of their rights in this country and send them off to a terrible prison in El Salvador, then, you know, who's next? Now, I will use my voice, and I am recognizing that people who are younger may feel they can't do that. Monica and I and the other book editors have had discussions about, for the contributors to our book right now, some of them are saying they're not sure they can put their name on the chapter. We understand that, and we're not judging. I can use my voice. What are they going to do to me? I'm 76. They want to send me to El Salvador, send me to El Salvador, you know? So if those of us who are older can't get out there and use our voices, then how can we expect the younger nurses to do that? I hope they will, but I feel like I have to walk the talk.
Thank you. Very, very powerful. Diana, thank you for a wonderful conversation. And I'm going to turn it back over to Jen.
Oh, wow. Thank you so much, Dr. Mason and Dr. Wexler, for joining us tonight. It's I feel like I have no words to do it justice to wrap this up after this really powerful messages. Well, your career is truly inspiring, particularly for junior faculties like myself, and I deeply admire your proactive and courageous approach to navigating the uncharted territory. I think a lot of things that you mentioned are still true even in 2025. And I will carry forward your encouragement to embrace those serendipitous moments, and really thank you for underscoring the importance of engaging with politics in our profession. I think oftentimes we try to separate those two out, and I think the moments are, it requires different approach. So thank you to all our guests who attend tonight. Thank you for your time, and you will be receiving a survey later this evening. We encourage you to share your feedback about the program, and please have a wonderful evening. It's beautiful in Ohio. I hope it's wonderful wherever you are, and we'll see you next event.
And thank you so much. It's been a privilege for me to have this opportunity tonight and see so many friends and colleagues. Thank you all.